Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Wa salatu wassalamu ala Rasulillah. Thank you all for attending, and thank you for the organizing committee. Today, in the next 20 minutes, inshallah, we're going to be presenting fungal step-down therapy. I don't have disclosures. We will be covering some of the aspects of fungal step-down therapy through some of the case scenarios. And we will touch base on the advantages of this transition as well as some of the limitations. And finally, we will be talking about a few of the antifungals in the guidelines, in the pipeline that will help serve this purpose. All right. So as you all know, our workhorses of antifungal therapy in the hospital include the amphotericin B in figure A and echinocandins in figure B, and also the azoles in figure C. All of them have IV formulation, but what is special about the azoles is they have oral options or oral formulations, which can be a potential for step down or continuation therapy. So let's start with a case. We have a 30-year-old male who was recently diagnosed with Hodgkin lymphoma. He was admitted to the hematology floor for chemotherapy. Day 8 after chemotherapy, started to develop febrile neutropenia. His blood pressure was stable, and there was no specific focus of infection in history or examination that can be found. And the central line looked normal, as well as his chest X-ray. He was started empirically on vancomycin and meropenem, and on the 4th day, he continued to be febrile. And on that day, the blood culture is showing growth of yeast. So what would be the next best step in managing this patient? Would you start IV liposomal amphotericin B, start IV voriconazole, anidulafungin, or fluconazole? So let's see some hands. I know it's the afternoon and everyone is tired, but let's keep this interactive as much as we can. So who votes for A, please raise your hand. Start liposomal ampho B. I see one hand, 2 hands. Okay, 3 hands. Who votes for B? Voriconazole? Okay, 1 hand. All right. And who votes for C? Anidulafungin IV? Okay, more hands than before. And fluconazole IV, anyone? Okay, all right. Okay, so the answer is C. Again, there is no one answer here. Basically, all of them are good options, but we try to order them based on the candida species that we have, the resistance profile that we have in the hospital. If the patient received basically fluconazole as prophylaxis, this can indicate that his current episode might be with candida that is resistant to fluconazole. So we usually suggest to give echinocandin in such a situation. However, liposomal ampho B is a good alternative, especially if we're dealing with like resistance, for example, or if we are suspecting mold infection. Same idea for voriconazole. And this goes along with the IDSA guidelines that was published in 2016 for candida treatment in febrile neutropenia, where they stated that echinocandin is recommended as initial therapy in febrile neutropenia patients with suspected fungal infection. So back to this patient, the blood culture from both the central line and peripheral line grew candida albicans, which was susceptible to fluconazole. And the central line was removed, and the repeat blood culture was negative, which is reassuring. So what is the best next step in managing this patient candidemia? So shall we continue anidulafungin IV for a total of 2 weeks since negativity? Or shall we move to oral fluconazole for the same period? Shall we switch to IV fluconazole for the same period? Or shall we do stat retinal examination to rule out endophthalmitis? Right, so let's see some hands. Who votes for A, which is anidulafungin? Okay, one hand, طيب. Who votes for B, which is switch to oral fluconazole for the same period? Okay, one hand there. And what about C? Any votes for C, IV fluconazole? Okay. And who wants to start retinal examination to rule out endophthalmitis? Okay, so, all right. So the answer here is B, which is switching to oral fluconazole for the same period. So we have to uh, get a grasp of the patient susceptibility profile before we make our final decision for this patient plan. And luckily, in this case, it was susceptible to fluconazole. So now is the right time to go to fluconazole from echinocandin, especially if you are not suspecting drug-drug interaction, or if there's you're happy about the QT interval and there is no allergy from fluconazole, it will be appropriate time to switch to IV fluconazole. And if the patient is able to tolerate oral therapy with no vomiting, then you can also consider actually giving oral fluconazole instead of IV. So what about continuation on IV anidulafungin? That is also a valid option, but it comes at a cost of prolonged hospital stay and potential selective pressure that anidulafungin applies on the patient microbiota. What about the stat retinal examination? Well, we do retinal examination, but if this neutropenia episode expected to be quick, then we usually perform it after they recover the neutrophil, so the ophthalmologist can see some findings if in the eye, if any. All right, so some of the data suggesting this is coming from this study, which was an evaluation of early step-down strategy from IV anidulafungin to oral azole therapy for the treatment of candidemia and other form of invasive candidiasis. This was published in 2014. It was an open label, non-comparative study. It was multi-center in the US and in Korea, including more than 150 patients who were all adults and had positive candidemia in the blood with positive signs of sepsis. All of the patients have received IV anidulafungin for the first 5 days, but after that, it was up to the treating physician if they want to continue on IV anidula or if they can step down to oral fluconazole. So, or voriconazole, depending on sensitivity. And the criteria that was given, number one is clinical stability, becoming afebrile for more than a day, the ability of taking oral, of course. And here they looked at resolving neutropenia, but not persistently neutropenic patient. And the patient had to have cleared his candidemia. They looked at the response rate at 2 weeks and also at 1 month after therapy, which included both clinical and microbiological cure at end of therapy. So among this 250 patients, around 60% of them, which is 150 patients, they were able to be switched to oral fluconazole, but 100 remained on the IV anidulafungin. So when they looked at the results, basically they were comparable among the two groups with response rate around 84%, almost similar morbidity and mortality between the two groups. So that was one of the studies about non-neutropenic patients. What about neutropenic patients? There are many small studies that are talking about this group. I put one of them here for you. So in this two retrospective studies, they looked at cohorts of patients who are febrile neutropenia patients and received different regimens like amphotericin B deoxycholate, the fluconazole and caspofungin, and basically the outcome was similar around those groups. The other reassuring thing is about the bioavailability of the azoles themselves. And luckily, we have achieved more than 90% of bioavailability. And this makes whatever dose you give oral is almost identical to what you give through the IV form. So what does the IDSA says about stepping down to oral fluconazole? Well, they do agree, but of course they need more data on like randomized controlled trial if possible. But they do agree on the concept of stepping down to fluconazole for step down during persistent neutropenia in clinical stable patients who have susceptible isolates and documented clearance of their candidemia. So what about us? Can we apply this in our practice? Yes, we can, but you need to make sure that the patient have reached clinical stability with stable vital signs. Even if they're still neutropenic, it's okay. And the candida species has to be susceptible to fluconazole. The patient has to have cleared his candidemia, as we said. And the duration that the patient spent on IV therapy is 5 days or more. The patient should not be having active vomiting, of course, and the dose suggested is at least 400 milligrams daily after the loading. Let's take a look at this missed opportunity here. So in this study, they looked at 103 patients with candidemia, and they looked at their susceptibility profile. Of course, it will take a couple of days until it comes back. And all of this cohort was started on echinocandin. But 89 of the population were subsequently found to have fluconazole sensitive isolates. But the physicians decided for most of the patients that they would continue treatment with echinocandin, and only 35 patients were switched to fluconazole. And I'm sure that you guys have seen many patients like this in your practice when the physician wants to stick to IV anidulafungin with no real great need for that agent. So why we do all this? Why do we step down to oral therapy? One of the things is, of course, to cut down the cost of IV therapy. As you all know, the cost of developing and manufacturing IV therapy is more estimated by 20 or 25% more compared to the oral therapy, because it needs to be very sterile, and it will need to be under specific temperatures that the pill can handle usually. And sometimes you have potential side effects related to the IV medication itself. For example, the voriconazole IV form, it has the vehicle of cyclodextrin, which can accumulate in chronic kidney disease patient and can lead to some side effects. The other thing about stepping down, that if you do step down to oral therapy, this can lead to decreased length of stay in the hospital with associated costs, like, for example, the bed, the equipment, the staffing, and so on. And also can lead to decrease in hospital-acquired infection, hopefully. This will, of course, if you step down to oral therapy, this will decrease the need for IV line and associated complication like thrombophlebitis. And hopefully, if you choose a narrow spectrum antibiotic that covers the bug that you isolated, you will be able to reduce chance of antimicrobial resistance emergence in your patient, in your hospital, and also in the community. And finally, this can lead to patient satisfaction because they get to go home earlier. So fungal step-down therapy is part of the antibiotic stewardship or antimicrobial stewardship that is now a mandate by different accrediting bodies, including SIBAHI. So here we make sure that the patient have assessment of the treatment once the culture result is back. We talk to infection control and see if we have like an outbreak that we need to take care of. We use the shortest duration possible given in the evidence available. And we only prescribe antifungal when it's only needed. We educate the staff while treating those patients with fungal infection. We try to make sure that the source is controlled, and we support inter and multidisciplinary team approach. And finally, we make sure that the dose of the antifungal therapy is appropriate. So what about some of the issues that can hinder this? Some hospitals, they have delayed or even unavailability of susceptibility testing, especially for yeast. And this is really important. So if you see that in your hospital, please talk to the microbiology lab and see if they can get things done in-house, or otherwise they establish a channel to be done like as an outsourcing. Sometimes we have issues with drug availability or formulation availability, like you have the IV form, but you don't have the oral form. And in some cases, we do have difficulty finding therapeutic drug monitoring, like for example, cases of voriconazole. when you need to keep an eye on the level of the drug, as well as galactomannan to monitor the improvement of the patient with aspergillosis. And sometimes, depending on the hospital, you might not have the support of the antimicrobial stewardship team or dedicated ID staff. All right. So let's move on to case 2. This is a 24-year-old male with a history of AML, status post allogenic stem cell transplantation done 60 days ago, admitted with low-grade fever and dry cough for 5 days. There was no preceding upper respiratory tract or sick contacts. He recently moved from another city and unfortunately forgot to take his